Morning, EDIC 2 aspirants and our honorable faculty. Today's class is about endocrine, which would be conducted by Dr. Divya Manaswet. Over to you, ma'am. Now you can start.
Welcome everyone to the class today. So for our EDIC 2, we will be discussing about endocrine emergencies today. So we'll try to take it up on a case-based or a table-based pattern. So as you know, pituitary endocrine emergencies are not very common. We don't see them very commonly in our ICU. So sometimes we tend to not read about them that much. And you can definitely get one of these topics either as a case-based scenario they could give you as a long case, or you could also get it in your tables. So we'll try to cover as much as possible all the endocrine emergencies today. We'll make it an interactive session. So please try to participate as much as possible. So this is the first case, a 55-year-old lady. 55-year-old lady who's a known case of diabetes and hypertension on treatment with tablet losartan and dapagliflozin, who has presented with an abdominal pain, fever, vomiting, and altered sensorium. On examination, she's drowsy, responding only to pain. She's tachycardic, heart rate is 120, blood pressure is 90/40, she's hypotensive. Saturation is okay at room air. She's very tachypneic, respiratory rate is 40 per minute. Per abdominal examination is soft, there is a little tenderness. Clinical examination is showing some signs of dehydration, the skin turgor is poor. So we do a CT scan brain, which is normal. USG abdomen, because it's an acute abdominal kind of a presentation that shows only fatty liver, no other abnormalities. Your investigations are showing a hemoglobin of 14, WBC counts of 30,000 with normal platelets. Random blood sugar is 500. BUN is 17, creatinine is 2.3. There is hyponatremia and hyperkalemia. Your ABG, as you can see, pH 6.8, bicarb of only 15. 12, PCO2 15, anion gap of 22, lactate of 3.3. So the urine ketones in this case is 3+. So there is hyperglycemia, there is leukocytosis, there is AKI, hyponatremia, hyperkalemia, severe metabolic acidosis, high anion gap with a positive urine ketones. So can anyone tell me what could be the possible diagnosis? What is the differential diagnosis for this? So two diabetic emergencies, diabetic ketoacidosis and a hyperosmolar hyperglycemic state. Both these conditions present with hyperglycemia and an absolute or relative insulin deficiency. So what happens in DKA? It is a triad. There is hyperglycemia, ketonemia, and a high anion gap metabolic acidosis, whereas hyperosmolar state has got variable degree of clinical ketosis is present, and there is an alteration in consciousness, which may be there to a varying degree. Maybe coma is not there, but there is hyperglycemia, ketosis, and some degree of altered sensorium. So diabetic ketoacidosis, as you can see, there is presence of all three: hyperglycemia, ketosis, as well as a high anion gap metabolic acidosis. So why this happens? Why and what is the difference in the pathophysiology? How these two conditions differ from each other? So what happens in all these states is basically there is a absolute or relative insulin deficiency, meaning the net effective action of insulin is less, either because the insulin secretion is less or the insulin action has become ineffective. So what does that mean? Because an absolute insulin deficiency will lead to more lipolysis, there is more free fatty acid delivery to the liver, there is ketogenesis, ketonuria causes bicarbonate loss, there is a severe metabolic acidosis, which happens in DKA. So how DKA differs from hyperosmolar state is that HHS has got a relative insulin deficiency, not absolute. So the ketoacidosis is not that severe. So ketogenesis is there, but it may be minimal. Okay, so the common features in both of these is that there is an elevated counter-regulatory hormones. Like you have your catecholamines, your cortisol, your glucagon levels, which increase. Because of insulin deficiency and increase in counter-regulatory hormones, what happens is there is an impaired glucose utilization in the peripheral tissues. So there is hyperglycemia, there is gluconeogenesis, increased glucogenolysis, and this hyperglycemia ultimately causes a glucoseuria. There is an osmotic diuresis, because of which there is a loss of water, electrolytes, there is severe dehydration, which then affects the renal function, and you can present with an acute kidney injury. So this is how both these conditions differ from each other. So in this particular case that we saw, what is the precipitating factor in the history that you saw that could have given rise to this diabetic ketoacidosis or HSS? So the precipitating factor in this case is the use of SGLT1 in anti-oral hypoglycemic agent. So other factors which could lead to this kind of a state is anything like any acute syndromes like a myocardial infarction, a CVA, pulmonary embolism, pancreatitis, use of steroids, many medications can precipitate. SGLT2 agents which have been newly used for treating diabetes, there are certain cases which become more ketosis prone, in that if the oral intake is less, alcohol consumption, any surgery, any other drug intake can precipitate a DKA in these cases. So patients present with polyuria, they present with polyphagia, polydipsia, vomiting, abdominal pain. They can present like an acute pain abdomen. There is also dehydration, shock, acidotic breathing, that is Kussmaul's respiration. They are hypothermic commonly. Altered sensorium, coma may even be very severe, result in seizures as well. There are a lot of electrolyte abnormalities which we have to be very familiar with. So how to distinguish these two conditions and why these electrolyte abnormalities happen? So, 30% of patients will present with features of both diabetic ketoacidosis as well as a hyperosmolar state. And there are certain conditions like, for example, CKD, when there is already a metabolic acidosis, maybe due to a renal component. So in those patients, how you diagnose your DKA is if the anion gap is very high, more than 20, then that could possibly explain a simultaneous diabetic ketoacidosis in these states. So what happens to the sodium levels? There is hyponatremia. This hyponatremia is mostly because of a dilutional effect. Because glucose is an osmotically effective solute, it causes more fluid shifts into the intravascular compartment, and there is a dilutional hyponatremia. Also, there may be diarrhea, vomiting, which is associated. So that again causes a sodium loss. Glucoseuria also causes a sodium loss. So the corrected sodium, how do you calculate? The hyponatremia will be there. How do you calculate your corrected sodium? You have to add 2.4 to your sodium value for every 100 milligram of sugar elevated from the above 100. So if the sugars are 500, you have to add 2.45 times to your sodium value, and that is your actual corrected sodium. The second thing is hyperkalemia. So these patients usually present with hyperkalemia. This hyperkalemia is because of the insulin deficiency. It is because of volume depletion. It is because of the metabolic acidosis. The total body potassium content is actually low, even though they're present with hyperkalemia. Total body potassium is low because of the urinary losses. The diuresis, the ketonuria causes your potassium loss as well. If a patient of DKA presents with normal potassium or low potassium, it is a bad sign. Okay, the other thing is phosphate. Phosphate also, they present with normal phosphate, but the total body phosphate levels are actually low. Hypertriglyceridemia, hyperamylasemia, leukocytosis is other presenting features. If the leukocytosis, if the WBC count is more than 25,000, then you have to look for an infection. It usually indicates an infection. So in this patient that we saw, the clinical case that we saw, is it DKA or is it HHS? And if it is DKA, what is the severity? So how to distinguish these two conditions from each other? One is the presentation. DKA is very acute. HHS will occur slowly over a period of time. Over days to weeks also it can take. HSS will not have such severe acidosis as what we saw. So this is mostly DKA. And what is the severity? How do we know the severity? So this is how we stratify DKA into mild, moderate, and severe. So that stratification is based on the severity of the acidosis and the mental state. So severe DKA will have sugars of more than 250, but the acidosis will be very severe, less than 7 pH, less than 10 will be the bicarb, and the anion gap will be more than 12, and the patient might be stuporous or comatose. HSS, on the other hand, if you see, the acidosis is not that severe. The pH is more than 7.3, bicarb levels are more than 18, urine ketone is not that high. The serum osmolarity will be very high, more than 320. The serum osmolarity and the serum sodium is what contributes to the altered sensorium in a patient with HHS. So in a patient of HHS, and this directly correlates with your osmolarity. The more the osmolarity, the more is the drowsiness. So if you get a patient of HHS and the osmolarity is less than 320 and still the patient is drowsy, then you need to do some neuroimaging. You need to look for some other causes of drowsiness, because drowsiness is directly linearly proportional to their hyperosmolarity. Okay. So the case that we are discussing is severe diabetic ketoacidosis. So this patient was treated, started on an insulin infusion. Sugars are high, BP is low, started on vasopressor support. Fluid was given, normal saline 500 ml as a bolus. And then because the acidosis is severe, another 200 ml of sodium bicarb was also given. So after treating it in this fashion, after 2 hours, the hypertension has worsened. The ABG is now showing more increased worsening acidosis, and the hyperkalemia, initially the potassium was high, 5.3. The potassium has gone very low. So why did the patient worsen with this treatment? These are all the things you're supposed to treat with, right? Insulin, fluids, bicarb, but your acidosis is worsening. So why is that happening? See, the fluid deficit, there is a lot of fluid deficit. There is severe dehydration. Diabetic ketoacidosis, around 6 liters approximately. HHS will have around 9 liters of fluid deficit. So when you treat this patient, the first thing you start with is fluid replacement, not your insulin. So DKA, the treatment, initially you start with isotonic saline. You give around 15 to 20 ml per kg body weight per hour. Matlab in the first hour, you have to give 1 to 1.5 liter. After that, subsequently, when you've corrected the initial dehydration, subsequent fluids you have to choose according to your hydration status, your electrolyte status. Basically, your fluid deficit, you have to calculate your fluid deficit and give half of it in the first 12 to 24 hours. It has to be corrected. If you give insulin before you have started fluid, it is going to aggravate your hypotension. The benefits of giving fluids through these patients, it is you correct the hydration one. Your sugar levels will start coming down. Your counter-regulatory hormone levels will start going down. Your BUN will start going down. Also, your potassium levels will start coming down when you start the hydration. But your pH or bicarbonate is not going to change with IV fluids. Anytime if you are correcting overzealously with hypotonic fluids, you have a risk of cerebral edema. So when do you change from isotonic to hypotonic? Typically in DKA, when your sugar levels go up to around less than around 200 to 250. When it goes to 200 to 250 milligram per deciliter, that is the time when you switch over to hypotonic saline. DNS, half DNS. Ideally. So the rate at which your osmolality should reduce should be around 3 milliosmoles per kg per water per hour. Sodium should decrease by 0.5 millimole per liter per hour. If your osmolality or your sodium changes are more rapid, there is a risk of getting cerebral edema. So once you start with your fluid correction, you have to monitor your electrolytes as well. Then you have to, second thing you do is you start your insulin infusion. Insulin infusion, you have to start when your potassium level is more than 3.3. So do not start insulin infusion without correcting the potassium. So you start your, because it is going to worsen your hypokalemia. You start your insulin at 0.1 unit per kg, that is a bolus. then 0.1 unit per kg per hour. Glucose reduction has to be rapid. You do not want a very rapid correction in your sugar levels. So the rate at which you want your correction is not more than 50 to 70 milligrams per deciliter per hour of sugar. So once your sugar has come to 200, 250, you reduce your insulin rate. From 0.1, you come down to 0.05 units. Okay, when you change over your fluid also to half DNS. The other thing is your potassium replacement. So potassium replacement, you have to start when your potassium goes less than 5.3, because your total body potassium deficit is actually the potassium is low. So you need to start your potassium correction early. Otherwise, you will risk very severe hypokalemia with all the insulin and fluids that you're giving. So you start your potassium replacement. The approximate rate of correction they have said is 20 to 30 millimole for every liter of fluid that you replace. Okay, the next is your bicarbonate. So bicarbonate, replacing bicarbonate in this is a very controversial thing, because giving bicarbonate it can sometimes worsen the cerebral edema. It can delay the resolution of your ketoacidosis also, and it can cause severe hypokalemia. So you only correct your bicarb if you have very severe acidosis, like if your pH is less than 7, if your bicarbonate is less than 10, then you can give 100 millimole bicarbonate in 400 ml NS with 20 millimole of potassium correction over a period of 2 hours to maintain your pH more than 7.0. Once the pH is more than 7.0, you don't need to correct your, you don't need to give bicarb. Your insulin infusion itself is going to correct the acidosis. Okay, so this is about diabetic ketoacidosis, how you will correct. So how does this differ from your correction of hyperosmolar state? Ajahn, phosphate, you don't need to ideally correct. Your total body phosphate will be lower, but ideally in every case, you don't need to correct your phosphate unless there is a muscle weakness and all that is happening. So your hyperosmolar state, typically it does not have a very severe acidosis. So you don't need to give bicarbonate and all. You start with your IV fluids, similar to how you were correcting your this thing. You correct your potassium. You start your insulin infusion. So the insulin dose that you're going to give to this hyperosmolar state is lower, because once you start correcting the hydration status, the insulin resistance is going to improve, and you will need lesser doses of insulin compared to your diabetic ketoacidosis. So you start your insulin infusion at 0.05 units per kg per hour, and you switch over to lower doses of insulin and to hypoosmolar fluids when your sugar goes to 250 to 300. At that point in time, you need to switch over to a hypotonic solution. In hyperosmolar states, you need to monitor your sodium levels. You need to monitor your serum osmolarity, because your serum osmolarity, if you correct it more rapidly, also you risk cerebral edema. So that has to be a more gradual correction. Hyperosmolar state, you need to correct more gradually. As your serum osmolarity starts improving, the sensorium will also improve. So when do you say that your diabetic ketoacidosis or your hyperosmolar state is now resolving? So this patient's condition improves. Ultimately, the bicarbonate is increased, pH is increased, sensorium is improved. The patient has been started on diet, insulin has been changed over. So how do we know that it is resolving? Your sugar has to be less than 200. Your bicarbonate level has to be less than 15. Your pH has to be more than 7.30. Anion gap has to be more than 12. So this is when you go down on your fluids. You can think of switching over to subcute insulin if your patient is eating, started on oral diet, and you start subcute infusion and give 2 hours of an overlap of IV infusion whenever you're switching over to subcute infusion, subcute insulin. And so this is the signs that your diabetic ketoacidosis is now resolving. Okay. The serum osmolarity also has to be more than less than 320. So what are the complications that you expect to see? One is hypoglycemia can happen if you have a more rapid correction, if you're not monitoring your sugars properly. Hypokalemia can have cardiac arrhythmias, cardiac arrest also if it is not monitored and corrected. Cerebral edema can occur if you have a very rapid shifts in your osmolarity, or sometimes even the increased cerebral perfusion itself can give rise to cerebral edema. So the treatment of cerebral edema would be to give mannitol to ventilate the patient if required. Rarely you can get a non-cardiogenic pulmonary edema, probably a fluid overload state also, DIC with DK. Thank you. So there we will conclude our class for today with these cases.